This is an AP oral med production, to be used as a teaching tool at the user's own consent.
A medically compromised patient is a person suffering with medical disorders which may become compromised while treating other pathology. Some conditions that you need to be aware of include diabetes mellitus, pulmonary disease, asthma, COPD, bleeding disorders, thyroid function, cardiac disease, renal disease, liver disease, infectious disease. Diabetes may be due to reduced insulin or insulin resistance. Type 1 – insulin dependent. Type 2 – non-insulin dependent. The blood sugar should be maintained close to normal, which is less than 7.8 mmol per liter, range of 7.8 mmol per liter to 11.8 mmol per liter would indicate prediabetes. You need to prevent hypo and hyperglycemic attacks. Timing of the appointment in the day will be important so that you don't interrupt patient's medication or feeding, perhaps just after breakfast, and maintain the patient's normal medication regime. Make sure that the patient's sugar levels are controlled. Timing of appointments to allow for good sugar levels. Minimize stress and pain as this can affect blood sugar levels. Patients may be more prone for infections, therefore prevent and manage infections. Periodontal disease needs to be well managed. Avoid medications such as aspirin and steroids. For surgical procedures, the blood sugar level should be 6.7 to 10 mmol per liter. Antibiotics may be given prophylactically to prevent infection. Patients on anti-diabetic medications may have lichenoid reactions. Hypertension is defined as systolic blood pressure of 140 mm mercury or diastolic blood pressure is greater than or equal to 90 mm mercury, or any persons being currently prescribed antihypertensive medicine for the purpose of managing hypertension. Normal level is 120/80 mm mercury. Two types: essential, primary hypertension 90 to 95%, no identifiable cause present. Secondary hypertension, an identifiable cause exists. Example: vascular disease, Cushing's syndrome, obstructive sleep apnea, adrenal medullary dysfunction, and hormonal dysfunction. Risk factors for hypertension include age, contraceptive use, menopause, obesity, family history, race, reduced nephron number, diabetes, dyslipidemia, high sodium diet, excessive alcohol consumption, physical inactivity, fetal origins of adult disease, personality traits, depression, hypervitamin D, low education, socioeconomic status, tobacco use, stress. Factors that interfere with control of blood pressure include nonsteroidal anti-inflammatory agents, aspirin, selective COX-2 inhibitors, sympathomimetic agents, decongestants, diet pills, cocaine, stimulants, methylphenidate, dexmethylphenidate, dextroamphetamine, amphetamine, methamphetamine, modafinil, ephedrine. Alcohol, oral contraceptives, cyclosporine, erythropoietin, natural licorice, grapefruit, orange juice, acetaminophen, antidepressants, bupropion, tricyclic antidepressants, selective serotonin reuptake inhibitors, venlafaxine, monoamine oxidase inhibitors. Corticosteroids, dietary and herbal supplements, e.g., ginseng, ephedra, ma huang, bitter orange. Tacrolimus, graft versus host disease (GVHD) is a systemic disorder that occurs when the graft's immune cells recognize the host as foreign and attack the recipient's body cells. Graft refers to transplanted or donated tissue, and host refers to the tissues of the recipient. The classification includes, acute classic GVHD, presents within 100 days of transplantation with classical clinical features of acute GVHD. Persistent, recurrent, or late-onset acute GVHD, manifests with clinical features of classic acute GVHD but after 100 days of transplantation. Classic chronic GVHD, presents after 100 days of transplant with classic clinical features of chronic GVHD. Overlap syndrome, may present at any time post-transplant with features of both acute and chronic GVHD. Risk factors of acute GVHD are higher degrees of HLA mismatch, prior acute GVHD, gender disparity, older age of the donor and/or recipient, peripheral stem cell recipients, alloimmunization of the donor, cytomegalovirus and Epstein-Barr virus seropositivity. Acute GVHD usually involves the skin, gastrointestinal tract, and liver, and is seen in 70%, 74%, and 44%, respectively. It can also involve the lungs, kidneys, eyes, and hematopoietic system. It may also result in decreased responsiveness to active immunization. Chronic GVHD has many features in common with collagen vascular disorders and systemic sclerosis. In the oral cavity, chronic GVHD may present as lichen planus with a risk of development to oral squamous cell carcinoma that differs from the classical pathology and seems to be more aggressive in patients with stem cell transplantation. Management. Grade 1 GVHD is usually managed with topical steroids in an attempt to control local symptoms. Topical tacrolimus is an option for steroid-resistant disease. Grade 2 or higher requires the addition of systemic steroids, most commonly methylprednisolone 2 mg per kilogram per day in divided doses. In cases of GI involvement, the addition of a non-absorbable corticosteroid, budesonide or beclomethasone, is more effective than systemic treatment alone. Steroids should be avoided if a GI infection is present. Oral lesions are also mostly managed with topical steroids. Medication-related osteonecrosis of the jaw (MRONJ) is a major problem that can occur in people taking certain medications such as bisphosphonates and denosumab. It can be used to treat osteoporosis or cancer. Risk factors: bisphosphonate exposure, dental disease and procedures, age, sex, anatomical factors, medical issues and hereditary factors. The diagnostic criteria include 1. Current or previous treatment with antiresorptive therapy alone or in combination with immune modulators or antiangiogenic medications. 2. Exposed bone or bone that can be probed through an intraoral or extraoral fistula in the maxillofacial region that has persisted for more than 8 weeks. 3. No history of radiation therapy to the jaws or metastatic disease to the jaws. MRONJ pathophysiology, bone remodeling inhibition, direct effects on osteoclast formation, differentiation or function, angiogenesis inhibition, anti-angiogenic medications, such as vascular endothelial growth factor (VEGF) inhibitors, tyrosine kinase receptor inhibitors and immunomodulatory drugs, can be associated with MRONJ inflammation or infection. Innate or acquired immune dysfunction may lead to exacerbation. Genetic factors such as single nucleotide polymorphisms (SNPs) that were associated with the development of MRONJ are found in regions of genes associated with bone turnover. Management. Non-surgical therapy strategies include stage 1, 2 and 3 as shown. This utilizes local wound care, antimicrobial rinses and removal of well-formed bone sequestra. Antibiotics being used in stage 2 and 3. If these strategies are not successful, then a surgical approach may be utilized. The surgical procedures are also stage 1 to 3 and uses resection of bone depending on the stage. This will vary depending on if the M-ronge is in the maxillary or mandibular arch. These stages are all followed by periodic clinical and radiographic review. Thank you for watching an AP Oral Med production.